Welcome to the deep dive. Today we're really getting into the complex world of neuromuscular diseases.
Absolutely. These are conditions that, well, they can cause all sorts of issues, weakness, pain, sensory problems.
And they come from different places too, right? Some
Yeah,
inherited, some acquired later on.
exactly. And to make sense of it all, we're taking an anatomical approach, looking at where the primary hit is.
Okay, so breaking it down by location.
Pretty much. Is it the peripheral nerves, those lines going out from the brain and spine? Or is it the neuromuscular junction, that crucial spot where nerve meets muscle? Or maybe the skeletal muscles themselves. We'll also touch on peripheral nerve tumors.
Got it. And just to be clear for everyone listening, we're focusing strictly on the peripheral system today.
That's right. Issues within the brain and spinal cord, the central nervous system, even if they cause similar symptoms, those are covered elsewhere in our source material. Today is all about the periphery.
Okay, so for these peripheral nerves, you mentioned key components, axons and myelin.
Yes, those are fundamental for sending signals. The axon is the main transmission wire, you could say,
Yeah.
and the myelin sheath, made by Schwann cells, is the insulation around it.
And damage to either one. That leads to peripheral neuropathy.
That's the broad term, yes. Any disruption there can cause neuropathy.
So what about the specific systems involved in moving and feeling? The source mentions somatic motor units and sensory pathways.
Right. Think of the somatic motor unit as the command chain for movement. It starts with a lower motor neuron, its axon reaching out, the neuromuscular junctions where it talks to the muscle fibers, and then all the muscle fibers it controls. That whole team.
Okay, the whole functional unit for movement.
Exactly. And the somatic sensory pathway is how we perceive things. It begins at nerve endings in, say, your skin, travels along a distal axon into a sensory ganglion, then a proximal axon takes that info up to the central nervous system.
So outgoing signals for movement, incoming for sensation. A two-way street.
Precisely. It's how we interact with the world.
The source also mentions autonomic nerves. Where do they fit in?
Ah, the autonomic system. That controls all the involuntary stuff. Heart rate, digestion,
Yeah.
sweating. And actually, there are more autonomic fibers than somatic ones in peripheral nerves.
Really? But they're not the main focus in most neuropathies.
Generally, no. The classic symptoms we associate with peripheral neuropathy usually stem from the somatic system, but there are big exceptions. Diabetic neuropathy, for instance, often involves significant autonomic problems.
Interesting. So for the typical numbness or weakness, we're mainly looking at the somatic pathways. Now, speed seems important. How fast these signals travel. Axon diameter and myelin. How do they affect speed?
Critically important. It's like comparing a country lane to a highway. Thin, unmyelinated axons, slow conduction. Think some pain, temperature, autonomic signals, but large, heavily myelinated axons, very fast, essential for quick reflexes, fine motor control, light touch sensation.
So the myelin insulation is key for that high speed. How is it actually arranged? You mentioned Schwann cells.
Right, so in myelinated nerves, each Schwann cell wraps a segment of the axon, creating an internode of myelin. But these segments aren't continuous. There are small gaps between them called the nodes of Ranvier.
Ah, the nose. That's where the signal jumps, right? Saltatory conduction.
Exactly. The impulse hops from node to node, which massively speeds up transmission compared to traveling along the whole axon membrane.
And unmyelinated axons.
They have a different setup. A single Schwann cell might surround parts of several axons, but without forming that thick, insulating myelin wrap around each one individually.
Okay, so we've got the electrical bits, axons, myelin, nodes. But nerves aren't just wires in empty space. There's connective tissue too.
Absolutely. Nerves need structure, protection, blood supply. That's where the connective tissues are vital. You've got the epineurium on the outside, a tough layer around the whole nerve.
Okay, the outer sheath.
Then inside, axons are bundled into fascicles, and each fascicle is wrapped by the perineurium. That's a really important barrier layer.
Maintaining the internal environment.
Exactly. And then finally, around each individual nerve fiber, the axon and its Schwann cells, you have the delicate endoneurium. These layers provide strength, support blood vessels, and cushion the axons.
Right, that makes sense. A complex structure. So now that we have the anatomy down, let's talk about injury. Axonal, demyelinating, and neuronopathies are the main types,
Those are the three general categories of injury mechanism, yes.
Hmm.
Let's start with axonal neuropathies.
where the axon itself is the main target.
Precisely. The classic example, the prototype really, is Wallerian degeneration.
Okay, what happens there?
That's what you see when a nerve is physically cut, like in a major trauma. Everything distal to the cut, the part of the axon separated from the cell body, starts to break down and fragment. And the myelin sheath around that dying axon also disintegrates, forming these little spheres called myelin ovoids.
So the line gets cut and the downstream part falls apart.
Pretty much. Then macrophages, the body's cleanup crew, move in to engulf all that axonal and myelin debris, clears the path for potential repair.
So repair is possible, regeneration.
Yes, the proximal stump, the part still connected to the nerve cell body, can sprout new axonal branches. A structure called a growth cone forms at the tip, and it starts growing outwards, trying to find its original target.
And the Schwann cells help guide it.
They play a crucial role. Their basement membranes often remain intact and provide a scaffold or pathway for the regenerating axon to follow. But its slow work may be about a millimeter a day, and it's not always perfect.
Oh, so?
Well, initially, lots of branches might sprout, and the body has to prune back the ones that go astray. And even if connection is reestablished, the new myelin formed around the regenerated axon is usually thinner, and the segments are shorter than the original.
Which probably explains why recovery after nerve injury can take so long and might not be complete.
Exactly. Functional recovery can be a long road.
What if that regeneration goes wrong? If the axons can't find their way?
That can lead to a traumatic neuroma. It's not a true tumor, but a painful, disorganized tangle of regenerating axons, Schwann cells, and connective tissue that forms at the injury site when orderly regrowth fails.
A jumbled mess that can cause pain. Okay, so Wallerian degeneration is the clean-cut model. How do the axonal neuropathies we see from diseases differ?
The main difference is the timing and progression. Wallerian degeneration is acute, from a single event. In most disease-related axonal neuropathies, the damage is gradual, happening over time.
So you see degeneration and regeneration happening simultaneously.
Exactly. If you biopsy a nerve, you'll often see axons in various states, some breaking down, some trying to regrow. But often the damage outpaces the repair, leading to a net loss of axons over time.
And you mentioned it, a dying back pattern.
Yes, that's very characteristic of many toxic and metabolic axonal neuropathies. It's length dependent. The very ends of the longest axons, those going to your feet and hands, are the first and most severely affected. It's like the nerve fiber is dying back from its tip.
Which neatly explains that classic stocking and glove pattern of symptoms we often hear about.
Precisely. Numbness and weakness starting in the feet and hands and moving upwards.
And electrically, what's the signature of an axonal neuropathy on nerve conduction studies?
The key finding is usually a reduced amplitude of the signal. Fewer axons are working, so the overall signal strength is lower. But crucially, the conduction velocity, how fast the signal travels along the remaining healthy axons, is often relatively normal or only mildly slowed.
Reduced amplitude, preserved velocity. Got it. Okay, let's switch gears to demyelinating neuropathies. Here, the myelin is the main target, not the axon.
Correct. In demyelinating neuropathies, the primary damage is to the Schwann cells, or the myelin sheath they produce, while the axon itself is often relatively spared, at least initially.
Like stripping the insulation off the wire.
That's a good analogy. The myelin degenerates in segments along the nerve, often in a random, patchy way. This disrupts that efficient saltatory conduction we talked about.
And can the nerve repair this myelin damage?
Yes, there's a process of remyelination. Schwann cells, or their precursors, multiply and try to wrap the bare axon segments with new myelin. But similar to regenerated axons, these new myelin sheaths are typically thinner and shorter than the original ones.
So repeated cycles of demyelination and remyelination can occur in chronic conditions.
Exactly. And this can lead to characteristic changes, like the formation of onion bulbs, which we'll discuss later.
And the key electrophysiologic finding here. If axonal neuropathy shows reduced amplitude, what does demyelination show?
The hallmark of demyelination is slowed nerve conduction velocity. Because the insulation is damaged, the signal can't jump efficiently between nodes anymore. It has to travel more slowly along the demyelinated segments, leading to a measurable decrease in speed. Slowed velocity is the key sign.
Makes sense. Faulty insulation slows the signal down. Now the third type, neuronopathies. How are they different?
Neuronopathies are distinct because the primary hit is on the neuron cell body itself in the dorsal root ganglia for sensory neurons, or the anterior horn of the spinal cord for motor neurons. The axon then degenerates secondarily because its cell body, its control center, is dying or destroyed.
So the problem starts right at the source, the nerve cell itself. What causes this?
Things like certain viral infections, herpes zoster is a classic example, attacking sensory ganglia. Or some toxins, like platinum-based chemotherapy drugs, can be directly toxic to the neuron cell bodies.
And how does the pattern of symptoms differ from, say, the dying back axonopathies?
Because the damage originates at the cell body, the entire neuron is affected. This means dysfunction isn't necessarily length-dependent. You're just as likely to see problems proximally, closer to the body's center, as distally in the hands and feet, unlike axonopathies where the distal parts suffer first.
So the distribution can be a clue.
Okay,
We have the types of injury. Now, the anatomic patterns, mononeuropathy, polyneuropathy.
Right. These patterns describe which nerves are affected and how. Mononeuropathy is simple. Just one nerve is damaged.
Like carpal tunnel syndrome affecting the median nerve.
Exactly. Trauma, entrapment, localized infection, common causes. The deficits are restricted to what that single nerve supplies.
And polyneuropathy.
That means multiple nerves are involved, usually symmetrically affecting both sides similarly. And most polyneuropathies follow that length-dependent stocking and glove pattern we discussed, often due to underlying axonal dying back.
Okay. Then there's mononeuritis multiplex. Sounds like multiple single nerve problems.
Pretty much. It's damage to individual nerves, but in a random, haphazard way, not symmetrical. So you might get a wrist drop on the right from radial nerve damage and later a foot drop on the left from peroneal nerve damage. Separate events.
And what kind of condition causes that patchy pattern?
Vasculitis, inflammation of blood vessels supplying the nerves, is a common culprit. It can cut off blood flow to nerves randomly.
I see. And the last pattern mentioned is polyradicular neuropathy, root involvement.
Yes. This affects both the nerve roots as they exit the spinal cord and the peripheral nerves further out. This leads to more widespread, diffuse symptoms, often affecting both proximal and distal muscles symmetrically. Guillain-Barré syndrome is a prime example.
Okay, great overview of the patterns. Now let's dive into some specific neuropathies. The common complaints are numbness, pain, weakness, a huge range of causes listed.
It's incredibly broad. Inflammation, infection, metabolic issues, toxins, trauma, paraneoplastic effects from cancer, inherited defects. Let's start with the inflammatory one.
First up is Guillain-Barré syndrome, or GBS. Acute inflammatory demyelinating. Sounds serious.
It can be very serious.
Wow.
GBS is an immune system attack on the peripheral nerves, specifically targeting the myelin. It comes on rapidly, acutely.
And it causes paralysis.
Yes, typically an ascending paralysis. Weakness often starts in the legs and moves upwards, sometimes affecting breathing muscles, which can be life-threatening.
What triggers this immune attack?
Often it follows an infection, maybe a flu-like illness or a gastrointestinal bug like Campylobacter jejuni a few weeks prior. Sometimes vaccination is implicated, but the link is less common. The idea is molecular mimicry. The immune system targets the infection, but then mistakenly attacks nerve components that look similar.
So the immune system gets confused.
Essentially, yes. T cells and antibodies that should fight infection end up damaging the myelin sheath, or sometimes the axon itself in certain variants. No actual infection is found in the nerves.
Then what does this look like under the microscope?
You see inflammation lymphocytes, macrophages infiltrating the nerve roots and peripheral nerves. And the key finding is segmental demyelination, where macrophages are actively stripping the myelin off the axons.
How is GBS diagnosed clinically? What are the key signs?
Rapidly progressing weakness, often ascending, and areflexia loss of deep tendon reflexes early on are the big clues. Nerve conduction studies show slowing, characteristic of demyelination. And a spinal tap often reveals high protein in the cerebrospinal fluid, but very few white blood cells. That's called albuminocytologic dissociation.
Sounds like it requires intensive care. What's the outlook?
Mortality is low now, maybe 2–5%, thanks to better supportive care like ventilation. But recovery can be long, and maybe 20% have some lasting disability. Treatments like plasma exchange or intravenous immunoglobulin, IVIG, can help speed recovery by removing or modulating the harmful antibodies.
A tough condition. Now, what about chronic inflammatory demyelinating polyneuropathy, or CIDP? The chronic suggests it's different from GBS.
Yes, CIDP is the chronic counterpart. It's also immune-mediated demyelination, but it progresses over months or years, often in a relapsing, remitting, or steadily progressive way. It's defined as lasting longer than 2 months.
So a longer-term immune attack, what's the mechanism thought to be?
Similar players involved T cells, antibodies targeting myelin or Schwann cell components. Complement activation and macrophage-mediated myelin stripping are also implicated. A key feature seen in nerve biopsies in chronic cases is the onion bulb formation.
Onion bulbs, what are those?
That's where repeated cycles of demyelination and remyelination lead to Schwann cells proliferating and wrapping around the axon in multiple concentric layers resembling the layers of an onion.
A visible sign of chronic damage and repair attempts. How is CIDP treated?
Treatments aim to suppress the immune system long-term. IV, plasma exchange, and especially corticosteroids are often effective. Unlike GBS, CIDP often responds well to steroids, which can be a diagnostic clue. Other immunosuppressants might also be used.
And peripheral neuropathy can also occur with systemic autoimmune diseases like rheumatoid arthritis or lupus.
Yes, conditions like RA, Sjogren's, SLE can cause distal sensory or sensoromotor polyneuropathies, distinct from vasculitis, though vasculitis can also occur secondary to these diseases.
Speaking of vasculitis, you mentioned it causes mononeuritis multiplex by damaging nerve blood supply.
Correct. Inflammation of the small arteries supplying nerves, a vasa nervum, causes ischemia and nerve damage. It can present as mononeuritis multiplex, but also single mononeuropathy or even a polyneuropathy. It's seen in ANCA-associated vasculitides, polyarteritis nodosa, and also as a non-systemic form limited to the nerves. Biopsies show vessel inflammation and signs of nerve ischemia.
Okay, let's move to infectious causes. Leprosy is first. How does Mycobacterium leprae affect nerves?
M. leprae directly invades Schwann cells, especially in the lepromatous form. The bacteria multiply within the cells, leading to demyelination, axonal loss, and inflammation. It tends to affect cooler body parts, hands, feet, face, causing a symmetric polyneuropathy. A major problem is the loss of pain sensation, leading to unnoticed injuries and ulcers.
And the tuberculoid form.
That involves a strong cell-mediated immune response against the bacteria in skin lesions. The inflammation damages adjacent cutaneous nerves, but the nerve involvement is usually more localized, less widespread than in lepromatous leprosy.
Different immune responses, different nerve patterns. What about Lyme disease?
Lyme disease from the Borrelia spirochete can cause neurological issues in later stages, including painful polyradiculoneuropathy and cranial nerve palsies, especially facial nerve palsy.
And HIV/AIDS.
HIV infection is associated with several neuropathy patterns, likely due to immune dysregulation. Early on, you might see mononeuritis multiplex or painful radiculoplexus neuropathy. Later, a distal sensory neuropathy, often painful, is common. The exact mechanisms aren't fully clear.
Diphtheria, that's caused by a toxin, right?
Yes, the diphtheria exotoxin inhibits protein synthesis and can cause an acute peripheral neuropathy, often with severe bulbar, swallowing speech, and respiratory muscle weakness. Still a concern where vaccination isn't widespread.
And lastly, varicella zoster virus, the shingles virus.
VZV stays latent in sensory ganglia after chickenpox. Reactivation causes shingles a painful rash in a dermatome as the virus travels down the sensory nerve. The virus can cause neuronal death and inflammation in the ganglion, leading to axonal degeneration in the corresponding peripheral nerve. Sometimes motor weakness occurs in the same distribution, too.
Okay, quite a tour of inflammatory and infectious neuropathies. Now, metabolic, hormonal, and nutritional causes. Diabetes is the big one here.
By far the most common cause of peripheral neuropathy overall. The longer someone has diabetes, the higher the risk, up to 80% after 15 years. Affects both type 1 and type 2.
And the most common pattern is that ascending, distal, symmetric, sensoromotor polyneuropathy.
Yes, that's the classic presentation.
What's actually happening to the nerves in diabetes? It seems complicated.
It is multifactorial. Chronic high blood sugar leads to metabolic changes. One is non-enzymatic glycosylation, forming advanced glycation end products, AGEs, that damage proteins and trigger inflammation. Another is the polyol pathway, where excess glucose becomes sorbitol, which can deplete antioxidants like NADPH and cause osmotic stress. These contribute to oxidative stress and nerve damage.
So direct metabolic insults. Is there also a vascular component?
Yes, definitely. Diabetes damages small blood vessels, microangiopathy, including those supplying the nerves. This leads to thickening of vessel walls, reduced blood flow, and ischemic nerve injury. Hypolipidemia and hypertension often worsen this.
So a metabolic stress plus reduced blood flow. What does the nerve tissue look like?
Primarily, you see axonal loss, fewer axons. There's often ongoing damage, like degenerating myelin and attempts at regeneration. The small blood vessels in the nerve often show characteristic thickening and hyalinization.
How does this typically present for the patient?
Usually starts with sensory symptoms in the feet numbness, loss of pain temperature sense, balance problems. Also positive symptoms like tingling, burning, shooting pains, paresthesias. The loss of sensation is a huge problem, leading to foot ulcers, infections, fractures, and sometimes amputations.
And autonomic neuropathy is also common.
Yes, in 20–40% of those with sensory neuropathy, it can cause postural hypotension, dizziness on standing, gastroparesis, delayed stomach emptying, bladder problems, erectile dysfunction, sweating issues.
Diabetes also increases the risk of compression neuropathies.
Yes, things like carpal tunnel syndrome are much more common in people with diabetes, possibly due to tissue edema or other metabolic factors affecting the nerve susceptibility to pressure. Same for ulnar neuropathy at the elbow, peroneal at the knee, etc.
A truly systemic impact. What about other metabolic or nutritional causes?
Uremic neuropathy in kidney failure is common distal, symmetric, often axonal. Thyroid problems, both hypo and hyperthyroidism, can cause neuropathies. And vitamin deficiencies are important. B12, causing subacute combined degeneration and neuropathy. B1, thiamine, B6, pyridoxine, folate, copper, zinc deficiencies can all lead to peripheral neuropathy.
Okay. Moving on to toxic neuropathies. What kinds of substances damage nerves?
A wide range. Industrial chemicals like solvents, heavy metals, lead, mercury, arsenic. Therapeutic drugs are a big one, especially chemotherapy agents like vinca alkaloids, taxanes, cisplatin. And chronic alcohol abuse is a major cause, likely due to both direct toxicity and associated nutritional deficiencies.
Neuropathies associated with cancer. How does malignancy affect nerves?
Several ways. Direct infiltration or compression by the tumor can cause mononeuropathy or plexopathy. Meningeal carcinomatosis can affect nerve roots. Then there are paraneoplastic neuropathies.
Why, yes, the remote effects, the immune system attacking the nerves because of the cancer.
Exactly. The immune response against the tumor cross-reacts with nerve tissue. These can occur even before the cancer is diagnosed. Common types are sensorimotor neuropathy, sensory neuronopathy, often with anti-Hu antibodies in small cell lung cancer, CIDP-like syndromes, autonomic neuropathy.
And neuropathies with monoclonal gammopathies, like in multiple myeloma.
Right. Abnormal proteins, paraproteins, secreted by neoplastic B cells can damage nerves. IgM paraproteins often target myelin components like MEG, causing demyelination. IgA are also implicated. Poems syndrome is a specific example with demyelinating neuropathy. And amyloid deposition from excess light chains can also cause neuropathy.
Okay, then there are physical causes. Trauma, compression.
Simple but common. Lacerations cutting nerves, avulsion injuries stretching them, and chronic compression or entrapment. Carpal tunnel syndrome is the classic entrapment, compressing the median nerve at the wrist. But nerves can get trapped at the elbow, ulnar, knee, peroneal, and other sites too.
Finally, inherited peripheral neuropathies, a huge diverse group.
Extremely diverse genetically, but important to consider, especially as many don't show up until adulthood. Major categories are hereditary motor and sensory neuropathies. HMSN, also called Charcot-Marie-Tooth or CMT, hereditary motor neuropathies, HMN, hereditary sensory and autonomic neuropathies, HSAN, and others like familial amyloidosis.
Charcot-Marie-Tooth CMT is the most common.
Yes, about 1 in 2,500 people. It's not one disease, but many, caused by mutations in over 50 genes affecting myelin or axons. Clinically, it causes distal muscle weakness and atrophy, sensory loss, often foot deformities like high arches.
How is CMT classified?
Often by inheritance pattern and whether it's primarily demyelinating CMT1 or axonal CMT2. Demyelinating forms often show slowed nerve conduction and those onion bulbs on biopsy due to repeated demyelination.
Can you give examples of common CMT types?
Sure. CMT1A is the most common overall autosomal dominant demyelinating, usually from a duplication of the PMP22 gene. CMT1B involves mutations in the MPZ gene. CMTX involves X-linked genes like GJB1, connexin 32. CMT2 involves axonal damage, like CMT2A caused by MFN2 gene mutations affecting mitochondria.
And hereditary sensory neuropathies, they mainly affect sensation.
Yes, primarily loss of sensation, especially pain and temperature leading to injuries. Motor function is usually preserved, often axonal. Familial amyloid polyneuropathies also fit here, mostly due to TTR gene mutations causing amyloid deposition in nerves.
Wow, that covers an enormous amount on peripheral nerves. Let's transition now to the neuromuscular junction, the critical link between nerve and muscle.
Indeed. The NMJ is a highly specialized synapse. The nerve terminal releases acetylcholine, ACH, which crosses the synaptic cleft and binds to AC receptors clustered on the muscle fiber's membrane, the motor end plate. This triggers muscle contraction.
And when this junction malfunctions,
The result is typically painless muscle weakness and fatigue. Autoimmune attack, like in myasthenia gravis, is common, but there are also genetic defects, congenital myasthenic syndromes, and toxins that interfere here.
myasthenia gravis, MG, is the best-known NMJ disorder. What's the core problem?
It's autoimmune. In most cases, 85%, antibodies attack the acetylcholine receptors, AChRs, on the muscle side. In many of the rest, antibodies target a protein called MuSCO, muscle-specific receptor tyrosine kinase, which is important for clustering AChRs.
How do these anti-AChR antibodies cause weakness?
They disrupt transmission in several ways. They can block ECO from binding, cause the receptors to be internalized and degraded faster, and activate complement, which damages the postsynaptic membrane. Fewer functional receptors means weaker muscle response.
And the anti-MuSK antibodies.
They don't usually activate complement, but interfere with the proper organization and clustering of AChRs at the junction, again reducing functional receptors.
There's a strong link between MG and the thymus gland.
Yes, very strong, especially with anti-AChR antibodies. About 10% of patients have a thymoma, a tumor of the thymus. Another 70% or so, especially younger patients, have thymic hyperplasia, enlargement with lymphoid follicles.
How is the thymus involved?
The thymus contains myoid cells that express AChRs. The theory is that abnormalities in the thymus disrupt immune tolerance, leading to an autoimmune attack against AChRs that then spreads to the neuromuscular junction. The exact mechanism isn't fully clear, and older patients often don't have thymic issues.
What are the classic symptoms of MG?
Fluctuating weakness that worsens with activity and throughout the day fatigability. Eye muscle involvement is very common. Ptosis, droopy eyelids, and diplopia, double vision.
That eye involvement helps distinguish it from myopathies.
Often, yes. Weakness can become generalized, affecting limbs, swallowing, speech, and even breathing, myasthenic crisis. Anti-MuSK patients often have more neck, shoulder, facial, and respiratory weakness, sometimes less eye involvement.
How is it diagnosed and treated?
Diagnosis involves a history, exam showing fatigable weakness, detecting the antibodies, anti-AChR or anti-MuSK, and electrophysiology showing a decrease in muscle response with repetitive nerve stimulation. Treatment has drastically improved prognosis. First line is often acetylcholinesterase inhibitors, which increase ACH levels at the junction. Immunosuppressants, steroids, azathioprine, etc., are used to reduce antibody production. IV and plasma exchange help in crises. Thymectomy is often done, especially if there's a thymoma.
What about Lambert-Eaton myasthenic syndrome, LEMS? How does it differ?
LEM is also autoimmune, but the antibodies target presynaptic calcium channels needed for AC release. Clinically, weakness often improves briefly with exertion, unlike MG. It typically affects limb muscles, especially legs, and reflexes are often reduced but can reappear after exercise.
And it's often associated with cancer.
Yes, about half the cases are paraneoplastic, usually linked to small cell lung cancer. The tumor expresses the calcium channels, triggering the autoimmune response. Treatment involves drugs to boost AC release and immunosuppression.
And congenital myasthenic syndromes, CMS, these are genetics.
Right. Rare inherited defects in various NMJ proteins, presynaptic, synaptic, or postsynaptic, like the ACH receptor subunits or clustering proteins like rapsin. Presentation varies from severe weakness at birth, floppy infant, to later onset. Diagnosis needs clinical suspicion, electrophysiology, and genetic testing. Treatment depends on the specific defect.
Lastly, toxins affecting the NMJ. Botulism and curare.
Classic examples. Botulinum toxin, Botox, blocks ACH release presynaptically, causing flaccid paralysis. Curare blocks AC receptors postsynaptically, also causing paralysis. Both were historically important for understanding NMJ function.
Fascinating stuff at the junction. Okay, let's move to the final major area, diseases of skeletal muscle itself.
Right. Skeletal muscle has unique features. It forms from fused myoblasts, creating multinucleated fibers, myofibers. Adult muscle also has satellite cells, the stem cells for repair. And we have different fiber types, type I, slow, fatigue-resistant, aerobic, and type 2, fast, powerful, anaerobic, normally mixed in a checkerboard pattern. The nerve determines the fiber type.
And muscle disorders can be primary, myopathic, or secondary to nerve issues, neurogenic. Muscle atrophy is common in many conditions. Are there patterns of atrophy that give clues?
Yes. Neurogenic disease often causes grouped atrophy clusters of atrophic fibers corresponding to a lost motor unit. Dermatomyositis classically shows perivascular atrophy fibers at the edge of the fascicles are smaller. And prolonged steroid use or disuse often causes selective type 2 fiber atrophy.
Okay, let's compare neurogenic versus myopathic changes more closely. What else signifies neurogenic injury in muscle?
Besides grouped atrophy, you can see fiber type grouping. As nerves are lost and surviving ones re-innervate nearby fibers, you get large patches of muscle fibers, all of the same type, innervated by one neuron.
So loss of the normal checkerboard pattern.
Precisely. Denervated fibers become atrophic and angular. Re-innervation can restore size, but might change the fiber type.
And in primary myopathies, what are the typical changes?
You see segmental myofiber degeneration and regeneration. Part of a fiber dies, gets cleaned up by macrophages, myophagocytosis, and then satellite cells try to repair it. Regenerating fibers look different. They're basophilic, blue staining, and have large central nuclei. You also see variation in fiber size, sometimes hypertrophy, enlarged fibers. In chronic myopathies, regeneration can't keep up, leading to fiber loss, fibrosis, scarring, and fatty replacement. Cytoplasmic inclusions like vacuoles can also be seen in some myopathies.
Let's talk inflammatory myopathies. Dermatomyositis, polymyositis, inclusion body myositis were the traditional trio.
They were, though the classification is evolving. Immune-mediated necrotizing myopathy, IMNM, is now recognized, and many cases once called polymyositis are now seen as IMNM or linked to connective tissue disease. So pure polymyositis is diagnosed less often.
Let's start with dermatomyositis, DM. Skin and muscle involved. What's the thinking on pathogenesis?
It's systemic autoimmune. A key feature seems to be immune-mediated damage to small blood vessels, microvasculature, in muscle and skin, likely involving complement activation. C5b9 deposition is seen in capillaries. There's also evidence for a role of type I interferons. Various autoantibodies are associated, like anti-My2 linked to classic rashes, anti-Jo1 linked to lung disease, arthritis, the antisynthetase syndrome, and anti-P155-P140 linked to cancer-associated and juvenile DM.
And the morphology reflects this.
Yes, inflammation is often perivascular around vessels and in the perimysium around fascicles. The hallmark is that perifascicular atrophy we mentioned, fibers at the edge of the fascicles are smaller and undergoing damage. You see regenerating fibers too. CD4 plus T cells are often prominent.
Clinically, slow onset, proximal weakness.
Typically, yes. Difficulty rising from chairs, climbing stairs, myalgias, muscle pain are common. And the characteristic rashes, heliotrope rash, purplish eyelids, and Gautron papules, scaly patches over knuckle cells, knees. Dysphagia and interstitial lung disease can occur.
And it can affect children, juvenile DM, or adults.
Yes. Juvenile DM has some different features. More calcinosis, less association with certain antibodies or malignancy. Adult DM has a significant association with underlying cancer. Paraneoplastic DM, maybe 15–25% of cases.
Okay. What about immune-mediated necrotizing myopathy, IMNM?
IMNM presents with often subacute, severe weakness and very high CK levels. The key feature on biopsy is widespread muscle fiber necrosis and regeneration, but with minimal or no significant inflammation. It's strongly associated with specific autoantibodies, particularly anti-HMG-CoA reductase, often linked to statin exposure but not always, and anti-SRP signal recognition particles.
So, an autoimmune attack causing necrosis without lots of inflammatory cells visible.
It seems so. The antibodies themselves are likely directly pathogenic.
And polymyositis, PM now, diagnosed less often.
Yes. When it is diagnosed now, it refers to adult-onset weakness and myalgia without skin rash or the specific features of IBM or IMNM. It's thought to be primarily T-cell mediated, specifically CD8 plus cytotoxic T cells attacking muscle fibers. Morphology shows endomysial inflammation within the fascicles around fibers, with CD8 plus cells often seen invading non-necrotic fibers. No significant vascular injury like in DM?
Then inclusion body myositis, IBM, affects older adults.
Yes, typically over 50, it's the most common inflammatory myopathy over 65. Slowly progressive weakness, classically affecting quadriceps and finger flexors, wrist flexors. Dysphagia is common. CK is usually only mildly elevated.
What's the pathology? Is it inflammatory or degenerative?
That's the debate. It has inflammatory features similar to PM, CD8 plus infiltrates, MHCI upregulation, but it also has degenerative features characteristic rimmed vacuoles within fibers and inclusions containing proteins associated with neurodegeneration like beta amyloid and TDP43. There are also familial forms without inflammation.
And treatment response differs.
Yes. DM and PM often respond to immunosuppressants like steroids. IBM typically responds poorly, further suggesting a significant degenerative component.
Okay, let's quickly cover toxic myopathies. Statins are a known cause.
Yes, statins can cause muscle aches or, more seriously, toxic myopathy or trigger IMNM. Chloroquine hydroxychloroquine can cause a lysosomal storage myopathy. ICU myopathy involves myosin loss in critically ill patients, often on steroids. Thyroid issues, hyper or hypo, can cause myopathy. Alcohol can cause acute rhabdomyolysis, binge drinking, or chronic weakness.
Now, the huge category of inherited muscle diseases, congenital myopathies present early.
Yes, usually in infancy, floppy infant, often with stable or improving weakness. They have characteristic structural abnormalities in muscle fibers like central core disease, often RYR1 mutations, nemeline rods, nemeline myopathy, various genes, or centrally placed nuclei, centronuclear myopathy, for example, MTM1 mutations.
And muscular dystrophies, generally progressive, starting after infancy.
Correct. This group includes Duchenne and Becker, which we discussed extensively.
What about Emery-Dreifuss muscular dystrophy, EDMD?
EDMD involves mutations in nuclear envelope proteins, emerin or lamin AC, causes a triad of humeroperoneal weakness, cardiomyopathy with conduction defects, and early contractures.
Facioscapulohumeral dystrophy, FSHD.
FSHD affects face, shoulder girdle, upper arms first, autosomal dominant, complex genetics involving aberrant expression of the DUX4 gene.
Limb girdle muscular dystrophy, LGMD. Very diverse.
Extremely. Over 30 genetic types, dominant or recessive, all cause proximal limb girdle weakness. Mutations affect various proteins, sarcoglycans, dystroglycan processing enzymes, sarcomeric proteins, etc.
Myotonic dystrophy, known for myotonia.
Yes, the inability to relax muscles. It's autosomal dominant, multisystem, muscle, cataracts, heart, endocrine. Most common type, DM1, is caused by a CTG repeat expansion in the DMPK gene. This expanded RNA is toxic, sequestering splicing proteins and causing missplicing of other transcripts like the CLC1 chloride channel, which leads to the myotonia.
Inherited metabolic myopathies affecting lipid or glycogen use.
Right. Can cause exercise intolerance with cramps rhabdomyolysis, like CPT2 deficiency for lipids, McArdle disease for glycogen, or progressive weakness, like Pompe disease, a glycogen storage disease affecting lysosomes.
And mitochondrial myopathies affecting energy production.
Yes. Complex genetics, nuclear or mitochondrial DNA, affect muscle and often other high-energy organs, brain, heart, can cause weakness, ophthalmoplegia, eye muscle paralysis. Biopsies often show ragged red fibers due to abnormal mitochondrial aggregates under the sarcolemma and abnormal mitochondria on electron microscopy.
Spinal muscular atrophy. Yes, this is neurogenic, right? Affecting motor neurons.
Yes. Loss of motor neurons due to SMN1 gene mutations causes profound weakness and atrophy, often presenting as a floppy infant. Muscle biopsy shows large groups of atrophic fibers, denervated, mixed with some normal or hypertrophied fibers, still innervated.
Finally, ion channel myopathies, channelopathies.
Inherited defects in muscle ion channels, sodium, potassium, calcium chloride, cause altered muscle excitability leading to periodic paralysis. Episodes of weakness can be hyper or hypokalemic, myotonia, or susceptibility to malignant hyperthermia with RYR1 calcium channel mutations.
What an incredible range of muscle disorders.
Okay.
Last section. Peripheral nerve sheath tumors, schwannomas, neurofibromas, MPNSTs.
Those are the main ones, mostly derived from Schwann cells. They can arise anywhere along peripheral nerves, including within the dura. They have strong links to familial syndromes like NF1 and NF2.
Let's start with schwannomas, benign from Schwann cells.
Yes, usually encapsulated, often attached to a nerve, but separable. Common sporadically and in NF2. Often have NF2 gene mutations causing loss of myelin protein function. Microscopically, they have cellular Antoni A areas with Verroque bodies and looser myxoid Antoni B areas. Strongly S100 positive. Malignant transformation is extremely rare. Common site is the vestibular nerve in the cerebellopontine angle, acoustic neuroma.
Neurofibromas, also benign, but more mixed cell types.
Right. Neoplastic Schwann cells mixed with fibroblasts, mast cells, perineural-like cells. Associated with NF1 or sporadic, several types. Cutaneous, diffuse, and plexiform. Plexiform neurofibromas grow along nerves, like a bag of worms, and are virtually diagnostic of NF1. Only the Schwann cells lose neurofibromin function due to NF1 gene loss, leading to RAS activation.
And plexiform neurofibromas carry a risk of malignancy.
Yes, they are the main precursor lesion for malignant peripheral nerve sheath tumors, MPNSTs, in NF1 patients. The overall risk of MPNST in NF1 is 5–10%.
So MPNSTs are the malignant counterpart.
Yes. Sarcomas arising from nerves or showing nerve sheath differentiation. About half occur in NF1 patients from plexiform neurofibroma transformation, half are sporadic. They are aggressive, infiltrative tumors. Histology varies, but often shows fascicles of malignant spindle cells, mitosis, necrosis, can sometimes show divergent differentiation, for example, muscle, cartilage.
And briefly, the syndromes, NF1 and NF2.
NF1 is common, 13,000, autosomal dominant. Causes neurofibromas, all types, MPNST risk, optic gliomas, café au lait spots, Lisch nodules, due to NF1 gene mutations, loss of neurofibromin, RAS activation. NF2 is rare, 140-50K, autosomal dominant. Causes bilateral vestibular schwannomas, multiple meningiomas, ependymomas, due to NF2 gene mutations, loss of Merlin function.
This has been an incredibly detailed journey through neuromuscular diseases. From the nerves themselves to the junction to the muscles and the tumors, the complexity is really striking.
It really is. And understanding these intricate details, the anatomy, the specific pathologies, the underlying molecular mechanisms is just so crucial for diagnosis and for developing better treatments.
Absolutely. The interplay between genetics, immunity, metabolism. It's fascinating how many factors are involved.
It truly highlights the delicate balance required for normal neuromuscular function.
So as we wrap up, maybe a final thought for our listeners. Considering all the progress we're seeing in genetics and targeted therapies, where might this field be heading?
That's a great question to ponder. You know, with gene therapies, RNA-based therapies like exon skipping for Duchenne, more targeted immunotherapies, how might these continue to evolve? Could we see truly transformative treatments for some of these devastating conditions in the coming years? It's an area of intense research and I think considerable hope.
Definitely something to keep an eye on. Thank you for guiding us through this incredibly rich and complex topic today.
My pleasure. It's a fascinating and important area of medicine.